topic of pulmonary hypertension and fibrosis associated with patients with neurofibromatosis type 1 by Dr. Theodore Chung, Dr. Thomas O'Brien, and Juan Linares. As clinicians, we often come across cases of high educational value that merit being shared with others. Truth is that the amount of medical knowledge that we currently enjoy have been built in a case-by-case basis. Today, we would like to highlight the association of pulmonary arterial hypertension and pulmonary fibrosis occurring in patients with neurofibromatosis. Perhaps when we think about persons with neurofibromatosis, the first mental image that we would have is that of innumerable cutaneous peripheral nerve sheath tumors kind of populating the patient's skin and leading to physical appearance changes. Perhaps we often neglect to think about involvement of the internal organs, such as the pulmonary parenchyma and vasculature. This is of crucial importance because when under-recognized and underdiagnosed, morbidity and mortality will be increased. We had the privilege of taking care of a 67-year-old veteran woman in our local advanced heart failure clinic who presented with rapidly progressive shortness of breath during the span of 6 to 12 months. She was a non-smoker patient with a diagnosis of neurofibromatosis. Her primary care physician had ordered a transthoracic echocardiogram that had demonstrated the presence of very severe pulmonary hypertension. Her right ventricular systolic pressure was near systemic at 120 millimeters of mercury, and a very dense triangular shape tricuspid regurgitation envelope was identified, as well as interventricular flattening during systole and diastole. A saline bubble study was negative, and so was the ventilation perfusion scan, showing no evidence of chronic thromboembolic disease. Serology was obtained as part of a battery of tests to evaluate for her pulmonary artery hypertension, but no clear etiology was identified. A right heart catheterization was ordered to determine vasoreactivity profile and further therapies, but she was also started on pirfenidone after the findings of pulmonary fibrosis were identified at the basis of her lungs on a high-resolution computerized tomography. Although pulmonary arterial hypertension occurs only in 10 to 20% of those persons with neurofibromatosis, this is a clinical entity that is not well known, and such will be undertreated, underdiagnosed, affecting the patient's not only quality of life but also survival. Different therapies have been proposed, including inhibiting progression of the pulmonary fibrosis with agents such as pirfenidone, but also by trialing medications typically geared towards World Health Organization Group 1 pulmonary hypertension, depending on the findings of the right heart catheterization. In conclusion, neurofibromatosis is a very common autosomal disorder worldwide that occurs in 1 out of 2,000 persons. 10 to 20% of persons may have pulmonary involvement, which tends to be very rapidly progressive. This is an under-recognized problem, which will affect the patient's quality of life and prognosis. Even though medical therapy remains limited, there are some potential options if we appropriately diagnose this clinical entity. Thank you.